Good afternoon and welcome to the Links in Pink. We thank you for joining the Links in Pink and the YWCA for our breast cancer awareness event. As always with the YWCA, we like to start out with our land acknowledgement. The Lower Cape Fear YWCA serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples known today as the Cape Fear Indians and the Waccamaw Siouan Indian people. Living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous people are not relics of the past. They are still here, continuing to demonstrate their talents and gifts amidst the backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. To start now we would like to share a video. We hope that video introduced some startling facts and it will help us get the conversation started. Now we would like to turn the program into the hands of Sherry Shaw, who is the Assistant Dean of Student Success at the University of North Carolina at Wilmington and is also a member of the Links Incorporated. Thank you so much, Sherry.
Thank you, Janiqua. And hello, everyone. Thank you all for logging in to listen to this important discussion. The Links Incorporated has a long tradition of promoting and engaging in educational, civic, and intercultural activities that enrich the lives of Black communities at large. And as October is Breast Cancer Awareness Month, and the Links Incorporated understands the importance of this issue and would like to continue to raise awareness about the impact of breast cancer. Today, our time will be spent hearing from health professionals and breast cancer survivors as we discuss breast cancer awareness before, during, and after a diagnosis. With that, I'd like to introduce our first presenter, our Pink Power story, and our survivor story, Karah Bush-Whearley, a doctor in physical therapy. Karah is a 31-year-old doctor in physical therapy and a breast cancer survivor. After receiving a diagnosis at 29 years old, Karah started her cancer journey, which consisted of 6 months of intense chemotherapy, 6 months of targeted chemotherapy, multiple surgeries, including a bilateral mastectomy. Now, almost 2 years in remission, Karah prides herself on embracing the challenges and joys of life. As she continues life post-cancer, she strives to bring awareness to early detection and prevention of breast cancer. And before she speaks, I just want to continue to say how much I honor and appreciate Karah's grace for her sharing her story. Not only is she a friend, she was a former student, and just I'm in awe of her. So Karah, the floor is yours. Thank you so much for sharing today your story and your pink power.
Thank you, Sherry, for that great introduction. Hi, everyone. My name is Karah. So I'm just going to talk about my breast cancer journey with you all. The title of the program is Before, During, and After. So that's kind of how I'll pair the story. I'll talk about what my life was before, what it was like going through treatments, and kind of an update on how I am and what I'm doing after. So to start with the before, I was a typical woman in their late 20s. I had just finished school, graduate school, and was really settling into my career. I had a job that I loved. I enjoyed traveling, spending time with friends, and dating my now husband at the time, or now husband, but boyfriend at the time. Life was going really well. We had just purchased our first condo in Chicago, and everything was really going our way. Fast forward to May 2019, typical weekday. We had just got done eating dinner, just sitting on the couch, just like a normal day. And I felt like a weird sensation in my left breast, which kind of prompted me to feel around in that area. And it didn't hurt or anything. It was just a weird sensation. So I felt around and I felt a lump. And I wasn't the type of person who, did their regular self-checks every month but it definitely felt different from the other side, and it felt different from the other areas of the breast. It was about like 3 finger widths large. And I had my boyfriend at the time feel it, and he was like, yeah, this is kind of weird. You should definitely get it checked out. So the very next day I went to my gynecologist, and, she really validated my concern. She's like, yeah, I feel something right here. It's probably nothing, which is what I heard often. It's probably nothing, like you're young, but I'm going to send you to get a mammogram anyway. So maybe the next week I went to get a mammogram, and that was interesting, being, again, 29. Everyone else was at least 40 in the breast center clinic. And, I think after the mammogram, I kind of knew that this wasn't good. The tech was very lighthearted with me to start with. And then I think, after she took the images, she saw something on this screen, obviously that she couldn't tell me at the time, but her whole demeanor just changed. So in my mind, I was like, okay, I need to kind of brace myself and prepare kind of for the worst. After that, I underwent a battery of tests, like a biopsy of the lump to see actually what it was. And, the doctor called me a couple weeks later and, said, I don't have good news for you. Your results came back as cancer. And at that time, he told me that it was hormone negative, which I'm sure we'll hear later about, how you type breast cancer, so hormone negative wasn't a necessarily good or bad thing. That was just, kind of what the cancer was classified as. And the cell growth was a grade 3, so meaning it was a very aggressive cancer that was spreading pretty quickly. That very same day, I saw an oncologist, and she explained exactly what it was called. She didn't say breast cancer. She said you have an invasive ductal carcinoma. She couldn't give me a stage at that time just because more tests needed to be run. But she did tell me that at this point it was curable, but that the process to getting cured was going to be a long and a tough one. But that gave me some hope. I was like, okay, it's curable. I can do this. By any means necessary was kind of my motto throughout the whole process. So I started chemotherapy maybe a month or so, 6 weeks after my diagnosis, and I had that kind of large gap in between because I did undergo fertility treatments. Having a family was something that was important to me, and I was told that chemotherapy could cause infertility. So it was important that I wanted to freeze my eggs before I started therapies. So my chemotherapy took about 6 months. I did 6 rounds of, I call it like intense chemo, because it was 4 different medications. So 2 of them were just like a general chemotherapy, and 2 of them were targeted for my specific type of cancer. So I was found out to have hormone negative but HER2 positive breast cancer. So 2 of those medications targeted that HER2 protein on the cancer. After I ended the 6 months of intense chemo, I went on to do just the targeted treatment. So that lasted about another 6 months. So in total, chemotherapy was about a year long. After the intense portion of it, which ended in October, I underwent a bilateral mastectomy, which basically means all of the breast tissue on both sides was removed. So the fatty tissue, the nerves, the milk ducts, everything just gone. And at that point, I was left like completely flat with what they call like expanders in there. So just to prep for my reconstruction. And so I was given like a few weeks to recover after that. And then I went through a few other surgeries, like reconstruction surgeries. To go back to chemotherapy, that was kind of like the biggest thing and what I get most questions about. It wasn't kind of typically what I say, like the media shows. Like I thought I was going to be like stuck in bed the whole time, like or throwing up. But it wasn't really like that. I mean, I did feel pretty bad, but I tried to keep my life like as normal as possible. I still went to work as much as I could. I really only took time off for days where I had the chemotherapy infusions and like the day after. Some of the side effects I had were nausea, lack of taste, which was terrible. I had like this horrible metal taste in my mouth. I had joint pains, a lot of things that people don't notice that chemotherapy affects like every cell in the body. So like your taste buds, my ovaries, I was pretty much like boosted into menopause, which was terrible. Again, like being in my late 20s, the fatigue was really bad. I would be like exhausted when I got home from work. Even like walking up a flight of stairs was difficult. So that made exercising difficult as well. But again, like I said, it was important for me to keep a type of normalcy in my life. So, working, I love my job. I work as a pediatric physical therapist, so helping kids is really my passion. So that was something that like really helped me going. And, it was hard for me to kind of communicate with friends and family the things that I needed, saying again, like I wanted to feel normal, but they were kind of like, what do you need? What do you need for me to do for you? And me being very independent, that was like hard for me to kind of let them in and, kind of help me with basic things that I didn't need help before. So now just kind of transition to after. One thing I think that's really important is that cancer treatment doesn't end when chemo ends or like when you're technically cancer free. So I was technically cancer free. After my surgery, they took lymph nodes out and examined the lymph nodes and examined the breast tissue and found no evidence of cancer. So as of, I guess it's just December 2019, I've technically been cancer free. But again, like I still have to go through the surgeries, finish the targeted treatment. So technically active treatment didn't end until maybe June 2020. Currently, I still go into regular doctor's appointments with my oncologist and with my plastic surgeon, my breast surgeon. So it's still very, like cancer isn't like out of my, isn't out of my vision. It's still very active in my life. There's actually not a day that goes by that I don't really think about cancer and, what I had to deal with. I see my scars every day. But there is kind of a portion of me that is able to look towards the future now. For a long time, it was hard for me. I was in survival mode. It was hard for me to look towards the future and kind of see, what the future had for me, especially with the pandemic as well. That made things a lot difficult. But I'm still able to grow and move on despite the setback of cancer. Sorry, I just got a message. So to talk more about experience getting treatment during COVID. So when COVID started, I was just in the targeted treatment version of my chemotherapy. So, I just have to wear a mask during the, during the infusions and everything, and they kept everyone pretty spread apart. I personally I felt like I was more cautious about getting COVID compared to my friends who hadn't been through this immunocompromising condition. So while my friends were still like getting together, I was like, nope, please stay away from me. So that was definitely different. And, and that's another part of like adjusting to your new normal post-cancer is recognizing that your experience is going to be different than your friends. Like I definitely don't like drink as much as I used to, like going out with friends and things. I'm more cognizant of staying healthy and trying to exercise every day. But I think it's just important to listen to your body and to know what you need, whether it's like physical, mental, and emotional. And I feel like, because of the cancer journey that I had, I have a better idea of what I need in all of those areas. So I'm happy to answer any questions or if there's anything that we feel like I should talk on more.
Karah, I just am in awe and of appreciation of you for sharing and for sharing the dark sides and the bright sides, sharing we understand that once you get that diagnosis, it is possible that you will spiral. You think about the things, thank you for sharing about freezing your eggs. These are things that happen, and these are things that people need to be aware of and people need to know. I think that I hope that you'll join the panel at the end, because I think we're going to get some questions, and I would encourage anyone listening, if you have questions, please put them in the Facebook chat. Janiqua and I are monitoring it, and we'll be able to ask those questions shortly after we move into another part of our presentation. So Karah, please stay on, and we'll definitely bring you back into the panel. But thank you so much for letting us hear that story and for sharing all aspects of it. I want to move us into an overarching conversation that's going to bring us to Dr. Khadijah Tribier-Reed. Dr. Reed is a mother, a wife, a pediatrician, and a public health advocate. Dr. Tribier-Reed is the pediatric medical director of Wilmington's only community health center, Med-North Health Center. She also serves as the vice chair of New Hanover Regional Medical Center's Department of Pediatrics. She's an avid supporter of early childhood education and has been appointed by Governor Roy Cooper to North Carolina's Partnership for Children's Board of Directors. She is also the medical consultant for her health center's Reach Out and Read program. And what we've asked Dr. Tribier-Reed to do is just to give us an overarching view around Black women and breast care health, and kind of really connect it to the surface as to what we're facing through social determinants of health. So I'd like to turn it over to you, Dr. Tribier-Reed. Thank you for your time.
Greetings, everyone. Thank you so much for having me. So, thinking about breast cancer health made me think not only about us and breast, it made me think about disparities in general in the African American community. And that took me down a really long road, which I'm going to share with you today. And I'll just say, it ain't pretty. It's not pretty. Women experience breast cancer differently than white women. So the number of new breast cancer cases are the same for African American women and white women. But the incidence of breast cancer before age 45 is higher among African American women than it is for white women. African American women are twice as likely than white women to be diagnosed with triple negative breast cancer, which is a more aggressive and harder to treat form of breast cancer. African American women are more likely than white women to die of breast cancer. Heard it before, we know it anecdotally from our own families: colorectal cancer, prostate cancer, COVID-19, hypertension, diabetes, HIV, AIDS, stroke. We have a lower life expectancy, a higher breast cancer death, and more obesity. These are all disparities which disproportionately impact African American women. Differences exist. And we have heard all types of thoughts about this throughout the years, right? Low educational level, African Americans just don't have the educational level. Poor participation in studies. There's not enough research done on us. More smoking, more alcohol use. The other comorbidities is more challenging. Late to diagnose it. True. We don't have enough time off work to do mammograms and get ourselves checked out. Just had a patient tell me that. We're religious, and so we trust God. We don't trust man and physicians. Poverty, having a poor diet. How many times have I heard if we just ate better? Partly true, for sure. Mistrust of the medical establishment, just good old-fashioned poor genetics. Late to screening, obesity, implicit bias, meaning in the healthcare space, healthcare providers may be biased in such a way that we don't get the same treatment as white Americans do. And not enough exercise, not having insurance, and no primary care doctor. All things we've heard throughout the years. Because I wanted to know the why behind the why. So if all of those are true, why are they true for us and not for other people? Yes, you can move forward. Thank you, Janiqua. Story time. Let's talk. Next slide. So in the 1600s, African people were kidnapped, enslaved, and shipped across the Atlantic Ocean to work without. For over 200 years, enslaved Africans were beaten, raped, separated from their families, and denied education. In 1865, slavery was abolished in the United States of America. Construction era, African Americans built businesses, schools, communities, and gain political power. So those of you who are in Wilmington, we just had a nice exhibit downtown, 1897. So the notorious 1898 riot, before that, there was 1897 and 1896 and 1895 when African Americans served in political offices, had businesses, and were very prominent. So just a few years after slavery, quite honestly, African Americans as a people rose to great success. In the late 1800s, in the US, white conservatives used violence and election fraud to disenfranchise African Americans. And we know that this happened in Wilmington. This is a picture from Wilmington. And in Rosewood, it happened throughout the country. This was something that dismantled the progress that African Americans had so quickly accumulated throughout time. And it was a movement. And in comes Jim Crow laws. So in the late 19th century, schools, housing, and libraries became segregated. American voters were disenfranchised. So let's just think about what that means. If you can vote, you can't vote African Americans in. You can't necessarily vote in people who are going to serve your interests. If housing is segregated, who gets the good housing? Who gets the bad housing? Remember that ghettos were by design. They were created. So this is Robert Taylor's You it in this moment right on the north side. And actually, this was the site of the first African-American housing complex. So when housing became segregated, this is where if you had to get public housing, you would be in this area. Now, of course, Robert Taylor Senior Homes has been reconstructed, but this happened beginning in the 1930s. Housing segregation was reinforced through legislation, other practices like redlining, exclusionary deed clauses, and other measures. So just stop there for a second. So what that means is, if you were African American and you lived in a community that was predominantly African American, even if you owned your home was valued at a lower rate. It was hard for you to resell your home, which means that you could not accumulate wealth as other people could. You could not pass wealth to the next generations as other people could in this country. Exclusionary deed clauses meant there's no in not sell this house to an African-American person. So you find a house in a beautiful neighborhood, you can afford it, you can't get it. And buy into a neighborhood, into a good neighborhood where your property value will be preserved. And these are the type of practices that were implicit, but also law in the 1930s. Next slide. So when we talk about, I'm going to ask this, it'll be a rhetorical question, but whose community is this? Lives in the community in this picture with the liquor grocery and the WK Walmart super discount, or have little or no fresh foods and have little or no produce. They're quick stores. You can get your little Hugs sweet beverages. You can get your liquor. You can get some salty chips. But in terms of really making groceries, often we find predominantly African-American communities, those grocery stores are not there. And those are called food deserts. We can find one right here in the north side, ironically, the same place where the Robert Taylor Senior Home sits and where the first African-American public housing was created. We can find one right near Creekwood, relative food desert there. Looks very similar to this. Next slide. So African-Americans in the medical establishment, this moves on to another thought about why disparities exist. So from 1932 to 1976, there was the Tuskegee study. That's a long time, guys, 40 years. African-American men thought they were being treated for syphilis, and they were not. And so their diseases went on to progress. Keep in mind, syphilis is not just the irregular old STD. There are such things as neurosyphilis, which cause poor brain development. And those who did, you can imagine, certainly didn't trust the healthcare system after that and went on to, and that legacy lives on today. Next slide. Americans in the medical establishment. Here's Henrietta Lacks, 1951. This is a woman who had cervical cancer. She was treated, maybe not, but she was treated, often without a lot of pain medication. Her cells were unusual in that they replicated very, very quickly. And so her cervical cells were taken and used and continue to be used in scientific study and experimentation without her knowledge. Those cells are called HeLa cells. And any of you guys who were in a biology class or have kids in a biology class have heard of those HeLa cells. They're named after this African-American woman, Henrietta Lacks. Next slide. All right, so adverse childhood experiences. So this is where I sit often. In the late 90s, there was a study done by Kaiser Permanente to a psychologist and a physician, and they were noticing a correlation between obesity and perhaps adversity in childhood. So they did a study. Once again, 17,000 people. That's a big study where they asked them several questions. Are your parents or guardians separated or divorced. Any parents had jail time or been to prison. Have you ever been without food, clothing, or a place to live? And so they could score each one of these things that were positive. So if the parents were divorced, that's 1 point. If a parent was in prison, that's a 2nd point. If a parent was mentally ill, that's a 3rd point. The number of points a person had correlated with adult illness. Next slide. Example. Go back one. All right. For example, a person who had 4 or more ACEs, those are those adversities I listed, was twice as likely to have ischemic heart disease, almost twice as likely to have cancer, 4 times as likely to have COPD or emphysema, and 10 times as likely to ever have injected drugs. There was a strong correlation with those adversities. So what I want to make sure we're clear on is understanding who is more likely to experience those adversities. Who is more likely to be incarcerated? Odds, 1 in 3 African-American men are predicted to be incarcerated in a lifetime, as opposed to 1 in 9 white men. So a lot more African-American children are growing up with fathers experiencing. Was more likely to be poor based on the disparity history I gave you. So those ACEs we know are more prominent, unfortunately, among African-American because of some of the structures we described previously. Is a thing, it's an unfortunate thing. What we've realized is that, and this study was done with trainees, but we realize this reflects other views in medicine. Half of white medical trainees believe such myths as Black people have thicker skin or less sensitive nerve endings than white people. An expert looks at how these false notions and hidden biases fuel inadequate treatment of minorities' pain. So this is a study, 2020, that came out. Next slide. Black newborns are more likely to die when looked after by white doctors. This was a heart-wrenching one, but once again speaks to this concept of implicit bias. Once again, another study that kind of showed that there were disparities in treatment that were often based in race. Right. So why do these differences exist? So we've got all of these thoughts and things we've thought of throughout the years of why disparities exist. But when people lay a disparity in front of you, I want you to go back and say why about 5 times. If they tell you it's because we don't eat right, then say, why don't we eat right? Then they say, well, there's no grocery stores in the community. Why aren't there grocery stores in our community? And you just keep going until we get to the root of the problem, because that's what we're going to really have to do to eliminate disparities. Next slide. All right, there is hope. I know it feels very gloomy, but there is hope. Politics and legislation matter. We have to vote. We have a local election happening now. Those are not moot points. We need to get out and vote and change the way the system engages with us. Increasing availability of universal screening eliminates disparities. This really helps if we can encourage one another to go ahead and take advantage of BSEP and Pink Ribbon and our insurance and just getting our mammograms done. Find a primary care doctor and get your mammogram. Tell other people to do the same. These are the conversations we need to be having in our communities. Seek information, have conversations, find opportunities to thrive. I want to thank Karah for her testimony today. I hate that I missed it, but these are the conversations we need to have in our community. Next slide. All right. And I think we'll have time for questions at the end. That concludes my presentation.
Thank you so much for taking us down that journey of helping us understand that this is systemic, that it's rooted in a lot of different issues, and that it does include the way our health outcomes are focused. So I think sometimes we like to compartmentalize healthcare, and we can't do that. And also we need to continue to break down these myths around our healthcare and even around breast care. So I think it perfectly ties into exactly what our next presenter, Ms. Karah Keenan, is going to talk about. So I'd like to introduce her and let her take us on a journey of these myth busters that we're going to speak about. So again, thank you, Dr. Tribier-Reed. Thank you, Karah Bush. And now we're moving to Karah Keenan. Karah Keenan is the founder and executive director of Going Beyond the Pink. As a decorated veteran, Karah served in the Air National Guard for 6 years, including a deployment to Iraq in support of Operation Iraqi Freedom in 2003. In 2013, Karah was diagnosed with breast cancer at the age of 35. The diagnosis ultimately changed the trajectory of her life and led to the understanding that our local community could do so much more to help women and men with breast cancer. As the founder of Going Beyond the Pink, Karah is passionate about serving members of the breast cancer community on their path to wellness. She strives to provide resources and educational programs to our local breast cancer community so that they can be their best health advocates and truly thrive. Again, advocacy. To further this effort, she developed the region's only comprehensive source of wellness-related cancer education. I've asked Karah to take us through a couple of common myths associated with breast cancer. Karah?
Thank you, Sherry. Thank you to everyone on this today and for everyone attending. We know that, education equals empowerment, right? And this is so, so important. So I thank you all for taking the time and for inviting me to be even a little bit of a part of it. Thank you for pulling that up. Let's see. All right. Well, we're going to start right off the bat with some breast cancer myth busting. Thank you so much, Shaniqua. Okay, so if we look at this first one, the first thing I'd like to start out with is this really striking, kind of startling stat, right? Only 12% of Americans have a health literacy level that is high enough for them to understand and implement important health information. So how do we deal with that? What do we do with that information? Want to move on to that next slide? There are two key things, and I think that Dr. Tribier-Reed alluded to this as well, or not even alluded to, just said this straight out, right? We have to keep asking questions. So the same goes here. We want to ask questions, but we also want to make sure that we're challenging misinformation. There are so many myths out there or things that we hear that kind of become these culturally held beliefs that then go from generation to generation to generation, and we just assume that they're accurate because everyone believes the same thing, but it's not always true. So let's do this. Thank you. All right, let's move on to the first one. So myth or fact, and if you guys are in the comments or anybody wants to jump in and share their feelings on this, please do. But myth or fact, women with no family history of breast cancer have little or no risk of getting the disease. What do you think? I can see Janique was there going, myth, right? Yeah, absolutely. So this is a myth. What we know is that around 15% of breast cancer diagnoses are related to known genetic mutations. It's really important that we stress the known part because there are still lots of mutations that are variants of unknown significance. And so those are still being studied. But what we do know right now is that about 85% of breast cancer diagnoses are attributed to environmental factors. And these are both ones that are within our power to control and ones that are definitely not in our power to control. So just know that it's not always in your genetics that the reasons why we're getting that breast cancer. Next one, please. Okay, myth or fact, breast cancer only affects women. So, Janiqua, I missed you. What'd you say? It's a myth. Yeah, I'm watching you, girl. It is a myth. So we know that 1 in 8 women get breast cancer. That's about a 12% risk, average risk, right, in your lifetime. But for men, it's much more rare, but it does happen, right? 1 in 833 men will get breast cancer in their lifetime. And I love to bring this up, particularly in a space full of women, because in a lot of ways, we're the ones that are seeing our partners, and whomever that partner is, you can also be helping to look and notice for any changes in the breast tissue, right? Karah shared that when she found her lump that she had her significant other kind of feel it as well and say, is this different? I had that same experience in my own life. And, if you're walking around, you have a father, son, grandfather walking around without a shirt on and you see something that's different, make sure they don't ignore it because they are more likely to ignore those signs and not seek treatment and diagnosis for that. Okay. We are moving right along. Okay, so myth or fact? Women over 40 should have a mammogram every year. Is this a myth or a fact? I see Laura is shaking her head. Yes. So there is some differing opinions depending on which authority that you are paying attention to, but many agree that women over 40 should have an annual mammogram. But here's the thing, you should also really know your family medical history, right? Because we know that there are connections, right? I'm starting out by saying that it's not all genetic, but I am saying that family medical history is important. And one of the reasons that family medical history is important is when you know your family medical history and you're able to share that with your physician, you can together decide if you need to start screening earlier as well. So know your family medical history, but absolutely be getting those mammograms every year after you turn 40. All right, myth or fact, if I find a lump in my breast, it means I have breast cancer. I see some head shaking, that's right. Yes, this is a myth. Breast tissue by nature is lumpy, bumpy, right? And they're not always the same. They're not the same size. They don't always look exactly the same. One of my physicians had said the girls are not twins. So breast tissue is lumpy, bumpy, but also there are lots of things that can cause changes in breast tissue. So finding a lump or finding a change doesn't always mean you are going to be diagnosed with breast cancer, but knowing your body and knowing what kinds of changes are normal for you and what aren't, that's really important. And when you find things that you cannot attribute to something like, I know I changed the type of soap I used and maybe that's what this rash is about, or I'm on my period and that's what these lumps and bumps could be about. But also we know that scar tissue and cysts also happen in breast tissue. So lumps or bumps could be things that are not cancer. All right, I hear this one a lot, right? We hear so many things like this causes, like broccoli causes cancer, broccoli doesn't cause cancer, or I can't really do anything because I'm just gonna get cancer anyway. So myth or fact, is there anything that you can do to prevent breast cancer? Yeah, so this one is absolutely a myth, right? We can, in fact, affect change in our own lives and change behaviors that affect our breast cancer risk. So let's go on and look at these in a little bit more detail. What's that next slide? Okay, so on the screen, you're seeing 4 different things. Are these myths or facts? Are these behaviors that can cause cancer? So we've heard this before. Do mammograms cause cancer? So we know that mammograms do emit a little tiny bit of radiation, but that the benefits versus the risk here, the difference is huge, right? The benefits of getting a mammogram absolutely outweigh any minuscule amount of radiation that you would be getting in getting the mammogram. How about birth control? Does birth control cause cancer? So this is really an interesting one, right? Back in the 90s and before that, there were some studies that showed links between certain levels of hormones that were used in birth control and later getting breast cancer. But modern birth control is quite different from that which we saw in the 70s, 80s, and 90s. And so that risk is not really nearly as high. And in fact, there are lots of studies that show it can have a protective benefit. So that's an important conversation. I won't say myth or fact. I'll just say that's certainly something to talk with your physician about and study and learn more. What about soy and coffee? I hear this, ingesting too much soy causes breast cancer or feeds breast cancer or mimics estrogen in our body. And caffeine. A lot of I don't know faces going on out there, right? So the soy thing is a really, really hot debate, particularly within the breast cancer community and those focusing on nutrition and breast cancer, right? What seems to be emerging is that some soy isolates, different parts of the soy when they are separated can have a detrimental effect, but eating whole soy foods like edamame soybeans, right? Or products or like soy burgers, veggie burgers, and things like that have that soy in it. As long as it's not broken down, it seems to have a protective effect and be beneficial to your health and not necessarily cause cancer. And caffeine as well. This is another thing, right? There's a lot of negative things associated with caffeine, but there are no real hard and fast studies out there that effectively say that caffeine can cause breast cancer. And another one, this is one I love to talk about, antiperspirants and deodorants. Who out there has heard that using antiperspirant will cause cancer? Yeah. And there's a lot of really convincing, I don't want to say data. There's a lot of convincing anecdotes out there that show it. I don't know if you've even heard like in circles about like with thermography and things where they see more inflammation or inflammatory impact when people are using antiperspirants with aluminum in them. So let's first break that down, right? A lot of antiperspirants use aluminum as the main ingredient. That's what helps to stop the sweating, right? So that you don't sweat through and make stains, right? Deodorants are more perfumes. So really there's no evidence to say that either one actually causes cancer. I personally like to put out there that there are chemicals in deodorants, right? The perfumes basically that we know aren't great for our overall health and can be endocrine disruptors. That's a whole nother conference we can have. And that the aluminum, right? There's no real studies that show this. So the biggest thing to take away from this one is personal choice, right? If you are a heavy sweater and you really feel strongly about using an antiperspirant so that you don't have to deal with those sweat things, then, you know, more power to you, but maybe look at the ingredients list when you're purchasing an antiperspirant and see what the aluminum levels are and maybe choose one that has a lower level. But ultimately, this is a myth, right? It does not, there's no scientific evidence out there to say that this causes breast cancer. All right, what about these? We've got another 4 up here. Myth or fact that these are behaviors that cause cancer. What do you think? All right, so yes, smoking we know is linked to nearly every kind of cancer out there. It's one of the controllable health behaviors that you can change to immediately reduce your risk of cancer. Obesity is another one, particularly if you are a woman that is postmenopausal. Being obese postmenopause absolutely raises your risk of breast cancer. Sedentary lifestyle, right? Sitting is the new smoking. That's what everyone is sharing out there. So get up and get moving, because we know that a sedentary lifestyle absolutely contributes to your cancer risk, and as does alcohol consumption. In fact, that we know that women particularly that drink more absolutely have higher rates of breast cancer. We're going to burn on through these here. So myth or fact. Birth control and hormonal treatments. So we talked about birth control already a little bit, right? That really doesn't contribute. But what about hormonal treatments for those that are going through menopause? Yeah, we know that hormonal treatments during menopause can absolutely contribute to hormonal breast cancer risk. Okay, what about a breast injury? Something slams into your breast, you fall, you've got a big bruise. What about that? An injury to my breast can cause breast cancer. No, that is not true. Total myth. Total myth. All right, and here's the other one, right? Underwire bras cause breast cancer. What do we think? No, they sure don't. They can cause, they can cause friction and breakdown and let infections in under your skin and all of that. And so it's still recommended that if you can avoid it, find another kind of really good, strong support. But underwire bras are not directly linked to any increase in your breast cancer risk. and the beast, right? Everybody wants to talk about sugar. So this is probably a little bit more complicated, right? This, as in terms of a direct link again, is a total myth, right? There is nothing that says if I eat sugar, I get breast cancer. However, we know that eating a lot of sugar does contribute to other things like obesity. And we see a lot of links between those who eat a lot of sugar and are obese and living a sedentary lifestyle. And so we know obesity and sedentary lifestyle are risk factors. So ultimately, it doesn't cause it, but should you eat a ton of it? Probably not. All right. I'd love to hear more from folks about which myths or facts surprised you, but I know we have so much more to get done. So I'm going to turn it over. Thanks so much for having me.
Hi, Karah. Thank you so much. That was so helpful and so valuable in regards to just as that breakdown. I know we had plans to do a panel, and as always, an hour goes by very fast, but I'm going to ask Laura if she could take us home, and I'm going to have 2 questions from the audience that I think are really valuable as we wrap up today. Before that, I want to tell you that Laura Clark is the clinical coordinator for breast oncology and a certified nurse navigator at Novant New Hanover Regional Medical Center and the Zimmer Cancer Center. Laura is a registered nurse with more than 23 years of experience in healthcare, and in her role, she works with a team of healthcare professionals, oncologists, and surgeons who are working to improve the breast care of cancer patients as they receive help and care in the community. So Laura, thank you for this time, and thank you for really providing the closing of this time. Karah, Dr. Tribier really did set the stage. One of the things that I've seen in the chat is, one, a lot of questions around how do you understand stage and type of cancer? Mm-hmm. And then also, what are quick things that we can do now? So if you had to tell us 5 things that we could do activity-wise, or 5 things that we could do for food, how can you help us understand those 2 major concepts as well as the type and stage of cancer?
Okay, lots to go over there, but let's take cancer, breast cancer, and into 2 different categories: estrogen positive and estrogen negative. So there are 3 different receptors that we look for to categorize. So we look for an estrogen receptor, a progesterone receptor, and a HER2, which is a human epidermal protein. About 20 years ago, Dr. Solomon from UCLA discovered this, Dr. Slayman, this human epidermal protein, that it increased proliferation rates and caused cancer to grow faster. And Karah Bush, who was saying she was HER2 positive, she had a targeted therapy. So we understand those receptors. We know what kind of medications attack those cells. Okay, and it gets tricky because grade and stage are different. Don't get hung up on those things. There is something called a clinical stage and a pathological stage. A clinical stage is given after a biopsy. A pathological stage is given after surgery. So don't get hung up on those things. Get hung up on the things that you can do. And Karah, both Karahs, but Karah McKenna, just from going beyond the pink, I've worked a lot with some of you ladies in the community, and those the things that you can do. Get up and move. Get up and move. Get up and breathe. If it starts with 5 minutes a day, do it. It goes 10 minutes a day. Lunch hour. I have a standing desk in my office because I'm hyper, but after a while, you get tired. You get sluggish when you're sitting all day. So get up and move. Second thing, eat a plant-based diet. Try to choose foods that are more plant-based. So normally you get that cheeseburger, maybe opt for something else. Maybe opt for a veggie burger. Try them. They're not terrible. I even have my husband, who is the biggest meat eater I know, eating more plant-based foods. He made a vegetarian meal the other night. I'm like, I couldn't even believe it, because I told him I was interested in it and it tasted amazing. And so he's sort of, involve the cook in your house. The third thing you can do, I love my wine, but 1 glass is really what's the recommended. 1 glass, 1 cocktail, 1 serving of wine, or 1 beer is really what's recommended for the average female. Any more than that, your daily risk goes up with each consecutive drink. And the third thing, get your mammogram. If you are scared to get your mammogram, bring a buddy with you. there are so many programs now. We had the mobile mammography bus over at Martin Luther King Center the other day. These things are more accessible than ever. Yes, it's uncomfortable, but it lasts a very short period of time and it can save your life. So I have a friend that we call each other. We have our birthdays are close to each other. We hold each other accountable. Did you get your mammogram? It's like, ugh. But I always, right after my mammogram, I always go get myself something I want. I go purse shopping or go get a big piece of chocolate cake or have that glass of wine. That's what I do to reward myself for being healthy. So those are the things you can do. Very brief overview of how we understand breast cancer and how we treat it. And I'm so fortunate to work with you ladies. I've met Dr. Trevier. I met last year and the year before that. I just met Janiqua and Karah Bush, and I met Sherry Shaw at the Martin Luther King gathering the other night. And Karah and I work together all the time on an event, on a initiative. This is the last thing I'll say, called the Breast Health Equity Initiative. And our focus is women of color and getting women of color involved in their own health care and getting them their screenings. That's all I have to say.
This has been phenomenal. I wish we had an hour and a half or 2 hours because we could go on, and I would love to hear more from the audience. What I would say is let this be your starting point. Share this video with your friends, share your video with your family, start those dialogues around your family history, and maybe do it while you're walking. Yeah, so you can get moving. I do want to thank Dr. Trevier-Reed, Kara Keenan, and my love, Karah Bush, for sharing your story, being a part of this event, allowing us to be able to hear your personal perspectives, the historical perspectives, and things we can do now. I hope that this has been informational for you. It's been valuable for me. I also want to give a very special thank you to Janiqua Palmer and the YWCA, Laura Kate Fear, for managing the technological aspects of this, for keeping us on task, for sharing the videos. You've been phenomenal in the background, Janiqua. We couldn't have done this without you. Thank you so much, everyone. Have a great day, and we'll speak soon.